Hi, I'm Dr. Seth Force. I am the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University Hospital in Atlanta, Georgia. Especially for early stage lung cancers, that surgery is the recommended first line treatment for those patients. And typically that involves, as we mentioned, a lobectomy, and more specifically, it's usually a minimally invasive lobectomy. That's the standard of care. So this is either what's called thoracoscopic or video assisted thoracoscopic surgery or robotic surgery. And that's the standard practice. There are patients who may not be candidates for surgery. That's a very complicated question, and one that we looked at, my group at Emory looked at years ago. Risk stratifying patients for lung cancer surgery is very difficult. And there was actually an ACOSOG, a national trial that looked at this, and they came up with characteristics that they felt were considered high risk for patients. So we took those criteria and looked at patients we had operated on, and we actually had very good surgical results, even in what's considered the high risk group. So I bring this up because sometimes patients are deemed to be high risk or not operative candidates by non-surgeons. So by their oncologist, by their primary care doctor. And it's a very complicated algorithm in question. And the point being that every patient who is diagnosed with cancer, and especially in early stage cancer, should meet with a surgeon. And the surgeon should be the one to really weigh in or help to weigh in whether they think they're operative candidates or non-operative candidates. So what are things that would make people higher risk? Well, one of the key nuances about lung surgery is that we're removing breathing capacity when we take a lobe out. And typically that's anywhere from 15 to 20% of breathing capacity, depending on which lobe you're taking out. So if patients have advanced lung disease from smoking, they can have COPD, emphysema, or even other types of lung diseases, and they already have limited lung function. And we'll know because we always get breathing function tests, what are called pulmonary function tests prior to surgery. And if they already have limited lung function, if they're already on oxygen, then they may not be a candidate for that operation. But there's a lot of nuances in that, because sometimes the cancer's in an upper lobe, and that upper lobe has been completely destroyed by emphysema, and we can do a test called a perfusion scan to see how much function that lobe is providing, and it may not be providing much function at all. Therefore, you may not be taking a lot of lung capacity or breathing capacity away from the patient. And that's how complicated it is, that it's not just their breathing capacity, it's where is the cancer, what kind of operation would they need. So I mentioned that the lobectomy is the recommended treatment, but if they won't tolerate that, but they would tolerate what's called a wedge resection, where we just kind of snip out the spot, then maybe that's what we do. Other medical comorbidities, you can imagine, severe heart disease, is a main problem. If they have a very, poor heart function, or if they're high risk from a cardiovascular or coronary artery disease, then that also may weigh in. One of, I think, the biggest factors is kind of patient frailty, and it's something that gets overlooked. But we can do a successful operation, but if the patient never really has a good quality of life after that, then did we really do them a service? And my group at Emory is also looking, and we've been doing this for a while, at what are called patient-reported outcomes. So when the patients come to clinic before surgery and every time they come after surgery, we have them fill out a questionnaire about their performance status. And we've found that patients who elect not to have surgery, not surprisingly, have a poor reported performance than patients who elect to have surgery. And I think that's going to become very important down the road, that we're going to be looking at not just did we get the cancer out, did we get the radiation done successfully, but how are the patients doing a month, 6 months, a year, 18 months after that treatment. So I think, in a summary, there is no definite algorithm to say a patient is or isn't a candidate. It requires a lot of testing, a lot of thought, and a lot of discussion with the patient as to whether they're candidates for surgery. And I would say the most common scenario is not, oh, I'm sorry, you're not a candidate for surgery. It's, you're a candidate, but you're a higher risk candidate. You're a higher risk for having complications after surgery. You're a higher risk for needing oxygen the rest of your life. You're a higher risk for developing major pulmonary complications after surgery. Do you want to accept those risks or not? And so the way we usually do it is, I talk to the patient, I explain the risk to them, and they're often the ones making the decision about which, how they want their treatment to be handled. Occasionally, I had a patient a few weeks ago who was on a lot of oxygen at baseline, had very limited lung function based on the breathing function test. And I told her she was not a candidate. She would have been extremely high risk for a major respiratory problem and not really making it out of the hospital. So that occasionally does happen.